Well, hello, welcome. This is Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center. And tonight we've got Dr. Jay Manikin and we've got Sterling Grimes. And they are both from UNC Healthcare Systems. And Dr. Manikin is a hematologist and oncologist, which means that he specializes in blood diseases and in cancers. So we're going to be talking about that tonight. You know, we really have a great cancer facility over at Nash, don't we?
We do.
I've been over there a couple of times and it runs like a smooth clock, and I was there prior to COVID, of course, and they had, I think it was something about patients. They had a survivor day or something where patients had been treated and they came back, and so that was really nice. I really enjoyed that. It was great.
We do that annually.
Yeah, yeah. I just figured you probably didn't do it this year or last year.
Yeah, we weren't able to this year.
I know. We can't do nothing,
I
honey.
know. Hopefully soon. Hopefully
I know,
soon.
right. So, Dr. Manikin, you are, well, you're not really new to us anymore. You've been here almost 3 years. We were just talking about that. So tell me, what made you want to be a doctor? What happened to you to decide you wanted to do all that education?
I did well in school, and I was looking for what would be a good career for me, and medicine interested me. My sister is a doctor. Probably I was a little bit influenced by that.
Oh, okay.
And actually, we lived right very close to a medical school, so I was all
wow.
surrounded
Yeah,
by a lot of student doctors while growing up. And I did my medical school in India, and went to Madras Medical College, and came here for residency. And during residency, I had the opportunity to rotate through oncology at Fox Chase Cancer Center, and I really did like taking care of cancer patients. I do have some family background. I was touched by cancer too, and I was a cancer caregiver. So I thought I could understand the patients well, and so that's why I got into oncology, and I'm here.
Awesome. That's awesome. And how did we woo you from wherever you came to here? It's so great to have you here.
It's been a pleasure being here for almost 3 years now, and
That's
I do
good.
enjoy working at the
Good.
cancer center every day.
Good. Okay. So what's your typical day like? Do you have clinic patients where you talk about, I don't know, lymphoma or iron deficiency anemia, or
Yeah.
tell me about your day.
So typically, oncology is almost 95% outpatient practice. So we see patients on scheduled appointments, usually follow patients, and 3 to 4 new patients every day, and that could be a variety of patients. But generally, in most of the communities, Rocky Mount pretty much reflects many other communities of similar size. Breast cancer is the leading diagnosis. Lung cancer is the leading diagnosis. Here, due to the smoking in this area, head and neck cancer is also a leading diagnosis. So the volume of patients that I see also kind of reflects that distribution. And we see the new patients, talk to them about the diagnosis, work them up, and talk to them about treatment and get them through this journey.
Sure. So do you, is there a lot of hematology that needs to be done too? Or is it primarily oncology, or half and half? Or?
It's about 70-30. 70% is medical oncology, 30% is hematology.
Okay.
Among the 30%, probably majority of them are simple blood disorders like anemia, as you mentioned, iron deficiency, low blood count or high blood counts, but some of them could be cancerous blood disorders such as lymphoma or rarely leukemia.
And aren't there 2 different kinds of lymphoma?
There are
Probably more than that.
Yeah, so the older classification, and we still do follow that, you broadly divide them into Hodgkin's and non-Hodgkin's
Right.
lymphoma.
Right.
Thomas Hodgkin's is the guy who kind of diagnosed and characterized the Hodgkin's lymphoma. So anything that's not Hodgkin's is non-Hodgkin's lymphoma.
Okay, well, that
So
makes
there are like probably 70 subtypes if you
Okay.
classify it really detailed under non-Hodgkin's lymphoma. But that would be the major ones.
How many blood cancers are there? There's lymphoma,
There are,
obviously.
yeah, there are many that involves the bone marrow or the blood system. You know, you got acute leukemias, you got different subtypes under them. You got chronic leukemias. Leukemia, everybody gets scared when you hear the word leukemia,
Right,
but there are
right.
some chronic leukemias. The word chronic means it goes on forever.
Right.
And many patients do well with treatments for several years, sometimes decades. Some patients don't need treatment immediately. So there's it's kind of hard to put them in one basket, but then you got other, we call it myeloproliferative disorders, where your bone marrow starts to produce one type of cells more than the others, and then they occupy the bone marrow and they don't produce other good cells. So all those are also there.
Is there anything that is like so highly skilled that you need to send to like Chapel Hill, UNC, or
Yeah.
can you handle most of it here?
We handle most of it, but we will be the first ones to tell the patient that we probably should be sending you to Chapel Hill when we think that is necessary, especially with malignant hematology or the lymphomas and leukemias. If there's something that's really rare that we don't handle it often, I do partner with Chapel Hill and send them to a disease-specific team where that doctor just does that day in and day out, and the patients come back and get their treatments closer to home. And we do have affiliation with UNC, and we are all known to each other. We call them, we speak to them quite often.
Yeah.
Particularly leukemias, you need induction chemotherapy a lot of times, bone marrow transplantation. So those are more complex inpatient things that
Right.
need to be done in a tertiary center.
And do you treat children there as well? I hate
No.
to even think about it,
Yeah.
but it happens.
Chapel Hill probably does, but generally in the United States, the pediatric and the adult world is totally different.
Okay, like in
So-
everything else.
Correct.
Yeah,
Yes.
okay.
Yes. Yes.
And so the Cancer Center, I think it's so great because if you have started at Chapel Hill or you needed to go there for something and then you could still come back home and still get your treatments in Rocky Mount, which is so good for the patients.
Correct. Yeah.
So, and you obviously have a good working relationship,
Yes.
so you can, they say, I want this treatment, and you give it to them. And I just think that's awesome, because it's bad enough you've got the big C word, and it's bad enough you're sick and you don't feel well, and then to have to drive an hour and a half one way in horrendous traffic is
Yeah.
just, that's enough to make you sick right there, I think, so.
It's
I
really
think
nice
that's
to
great.
share the same electronic health record. So
Yes.
anything that Dr. Manicum were to document about the patient, the doctor at UNC can also see
Right.
that. Not just that they see the patient, but they also
Right.
see his records of
Right.
how the patient was
And
when he saw them.
that's great,
Yep.
because, even though you can get a detailed history and physical, sometimes things are missed, and so then they can look at all the labs themselves and
Yeah.
the imaging themselves.
I was about to say, more importantly, the CT scan, they can look at the film so that you
Right.
don't have to reinvent the wheel. That happens a lot of times.
Right.
When you go to places that are not affiliated, then they are not sure what's happening. Sometimes the
Right.
records go through, sometimes somebody drops the ball and it didn't get to that place, and then they had to order the whole thing again. So
Right.
that really is an advantage.
It is, for not only for the treaters, but the ones receiving the treatment.
Correct.
So that's awesome. Okay, we're gonna talk about all of your clinical trials, but I'm gonna hold off for that in just a minute. So I just jotted down a couple of questions here. So are there any environmental factors that can play a part in cancer? I mean,
Sure, definitely. Anything radioactive is generally associated with cancer risk, and radon is felt to be one of those. But how much that affects and how it impacts one person, it's kind of hard to quantify those. More than
okay.
environmental, personal habits such as smoking or occupational exposures, and the well-known one is asbestos that causes mesothelioma.
Right.
If you're exposed constantly to coal and dust and all those things. Apart from cancer, there are other inflammatory lung diseases that you could get, but I think what generally the people should know is about smoking, tobacco chewing, and all those things that are very, very carcinogenic.
Yes, and so very popular in this part of the state. I had a question and I lost it. Imagine that. So, what about like waters, stuff in water? Would it be the radon in the water? Anything else in waters around here, or you don't know?
I'm not sure about this. Sometimes patients do ask about it. Those, it's kind of hard to say that without concrete evidence as a scientific person.
Are there a lot of cancers that are hereditary? I know like the BRCA gene in breast is hereditary, but is there other ones that are that way as well? I don't know.
There are, for example, the BRCA gene, there's BRCA1 and BRCA2, and it involves an entire axis of not just breast cancer, but also ovarian cancer, pancreatic cancer, prostate cancer. So somebody, mom had breast cancer and had BRCA, they had only all sons. That doesn't mean that the male child doesn't have to worry about it. They could get high-grade prostate cancer.
Is that from that same gene?
Mm-hmm. Yeah. And also, there are other hereditary cancer syndromes. They are generally rare. Still, majority of the cancers are sporadic or happen by chance than inherited. But we are learning more and more about this, hereditary cancer syndromes. 15 years ago, we didn't know that much about the BRCA gene. Now we know that there's now new genes such as ATM, CHEK2. Those are all coming up, and they're all. There's only little that we know right now, but 10 years from now, we might know more genes.
Exactly right.
So, but for example, prostate cancer in this part of the country, especially in African Americans, they get at a younger age, high-grade prostate cancer, more aggressive behavior. We know that now about 10% of prostate cancer, all prostate cancer, they could have a mutation. So when you take the number of people with prostate cancer, that translates to a very high number. So we introduced a program at UNC Cancer Center at Nash to screen every prostate cancer patients to check them, their blood if they have any mutation that put them at risk for this cancer, so that their family members can be aware and they can be counseled through medical genetics. We again partner with UNC on that, and the medical genetics department has been very supportive, and people don't have to even travel. We arrange for a telemedicine consultation service where the genetics folks talk to you, explain the pros and cons of this testing, and then give you recommendations of what your family members should do.
Wow, it's amazing, all the breakthroughs and all the wonderful ways that we can find out about this. So do you have like a program once a year to check prostate cancer? Like, I know
you remember years ago when people did mass screenings?
Right. Do you have anything like that?
No, I don't believe that's generally recommended like it used to be.
Okay. The men like it, that it's not recommended.
Yes, guidelines just kind of evolve and change, and that was one of the guidelines that has changed over the years.
And so I'm sure you work closely with the urologists here in town too.
Yeah, we do work closely with them. But in general, as a medical oncologist, we don't really get involved unless a patient is diagnosed with cancer. We don't normally screen for things because you don't want to get in contact with an oncologist if you don't have to.
No.
So.
They hear that word and they're like, oh, no.
Yeah.
All right, well, we're going to take our first break, and when we come back, we're going to talk more with Sterling and Dr. Manican, and we're going to talk about the clinical trials that they're doing over at Nash, because that's very exciting to me, and I'm really interested in hearing all about it. So don't go away. We'll be right back after these messages. Hang on.
At Down East Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Down East Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Down East Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
I came to the emergency room because I was having what seemed to be an episode of AFib. I was very, very scared and wasn't sure exactly what was going on. They told me that they were going to do a catheterization. I was just totally blown away. The kindness, the compassion, the nurses. I was treated better than I've ever been treated in my life. I was just so excited that I could do it here at home at Nash UNC.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports, to compression hose, to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, hello, welcome back to Here's to Your Good Health. We're with Sterling and Dr. Jay Manikin, and we are talking now, we're going to talk about the clinical trials that are going on over at the hospital at the UNC Cancer Center. I had no idea there was clinical trials going on there. This is a well-kept secret, I guess. I don't know. But anyway, so what is a clinical trial? What do you do with that?
So a clinical trial technically means that it is a research study that involves human subjects or people, real people, and it gets to this stage after going through several years, sometimes 10 years, 12 years of research. First in the lab, checking a particular drug, for example, on a cancer cell and see that if it works. If it works, then do it on multiple cancer cell lines. Then take it to animal models and make sure that the drug is safe and study the side effects, and then take it to what we call several phases of clinical trial. Now, phase 1, you give it to a smaller number of people after knowing that it's safe in animals and you kind of understand the side effect profile. Then you make sure that this is the right dose and these are the side effects, and then in phase 2 you move them to understand how what is the efficacy of that drug? Does it really work, and how well does it work? And also, again, monitor the side effects and all those things.
Sure.
And then you come to a phase 3, which is a larger study that involves sometimes several hundreds to several thousand peoples, where you kind of compare that newer treatment against whatever is the standard of care right now in that disease, in that stage, and then do it in a very randomized fashion, meaning sometimes it's a double-blind study where I wouldn't know whether the patient is getting the active drug or a placebo. By that, you kind of understand, remove all the biases, and then figure out if this new treatment is actually better than the existing treatment, which a lot of times it could be. So that's really, what a clinical trial is about. The word clinical really stands for doing it in, people.
Sure. Is this a passion of yours, the clinical trials?
Yeah, and
'Cause you want
bringing it to a community cancer center, it gives a lot of satisfaction, and it keeps you, in the forefront of medicine.
Sure.
We're a comprehensive community cancer center, and in order to keep that designation, we actually must offer clinical trials to
okay.
our patients.
Okay.
Not necessarily phase 1 clinical trials like he was referencing, but we must offer some clinical trials. So we've been, for a couple of years, doing gathering information. So there's registry trials where you just, one of them was about exercise and how patients did if they exercise versus not exercising. So the fact that we now have treatment trials that are actual medications that impact a patient's potential, treatment and longevity is what's so exciting, because that's what's really new for us.
Yeah, well, and, oh, geez, yeah. So what kind of clinical trials are you offering over there right now? Any particular drug or particular disease process, or?
Yeah. So, on a broader sense, as Sterling mentioned, we do have something called registrational trials where you're not getting an active intervention. If you're studying, for example, how does prostate cancer treatment affect your work? That's a trial that we have. It's more of a study where you're not going to be receiving a different medication, but it helps us and the scientific community understand how this impacts. So those are the health outcome measures that help the scientific community understand the effects of this treatment. We also have other registry trials where if you have a lung nodule, you get registered under that. But more importantly, what I'm excited about and what we have accomplished is that we've brought several phase 3 clinical trials, which are active treatment trials, where you are actually receiving a novel drug that is not yet approved in your community. That's very much similar to what you would have had if you had gone to Duke or Chapel Hill or other tertiary institutions. And I've been interested in breast cancer, so I focused on breast cancer because that's a large volume too, and that's of my interest too, and identified the need for example, triple-negative breast cancer. It's a very highly aggressive breast cancer where standard chemotherapy doesn't always equate to success in the long term. So immunotherapy, for example, is approved in a lot of other diseases. It's yet not fully studied in breast cancer. So we have a trial called B59 in which we partner with NSABP, which is a national cooperative group studying breast cancer, probably the best organization in terms of breast cancer research. We partnered with them and brought a clinical trial called B59 where patients diagnosed with stage 2 triple-negative breast cancer can receive a novel immunotherapy along with the standard of care chemotherapy, and that's really, it's an exciting trial for patients with this, aggressive disease. We also identified a couple of other breast cancers and introduced 2 more trials in that. We are opening up one more in probably 2-3 weeks from now.
Wow. So, wow. I don't know what to say, but wow, it's great.
We try to have trials or look for trials the physicians do that are geared around the patient population that we have. So breast cancer is our #1 diagnosed patient patient type at Nash, with over 180 patients unfortunately diagnosed with breast cancer last year. Now, of course, not all of those were triple negative,
Right.
but then lung cancer is another very popular thing for the
Gosh, I
physicians
hate
to
that.
research. No,
Right.
I mean for
Right, right,
around trials,
right.
just because it impacts
Sure.
our community
Of
so
course,
greatly.
Of course. So how do people, can I just walk in and say, hey, I got breast cancer, I want to be in a trial? I mean, how does that work?
So one of the good things about clinical trials is that they are very clearly defined. There's probably a 80 or 100-page protocol that we are given, and we had to follow that for sure. So if the way we identify patients for clinical trials is, say, for example, if you are a patient coming to see us, then when I go through your chart, I kind of identify, oh, this patient has this particular disease, and I think they will be eligible for our trial. So I alert the research trial coordinator, or they are also independently screening patients constantly for eligibility. Once we kind of preliminarily identify that somebody might be a good fit for the trial, then we discuss with the patient about what the trial is. We give them some information, and the trial coordinator also reviews and makes sure that they fit all the inclusion and eligibility criteria. And then we present all those information to the patient and ask them if they're interested in doing so. If they are, then we get something called a consent, and once that is done, then we do the necessary things that the trial requires to do in terms of additional CT scans or biopsies. A trial is more rigorously monitored than standard of care practice.
Sure.
So they always want to be 100% certain, so they might require an additional biopsy. Sometimes these biopsies go to centralized labs for another pathologist to confirm that this is the right diagnosis. We send it to Pittsburgh, for example, on our NSABP trials. And then once all these are done, then you're randomized. That means that the system will automatically randomize to either the novel drug or the standard of care treatment. But the good thing is about clinical trials that are in the phase 3 is even if you get randomized to a standard of care arm, you're still getting the best standard of care that's available today.
Right.
So that's really what I want people to understand, that just because it's a clinical trial, you're not becoming a guinea pig, and you're not just getting something or nothing. You're going to get a standard of care treatment. Either it's going to be standard of care treatment plus nothing or plus something that could potentially be a game changer for you.
Right. So you can't lose either way.
You cannot, unless you develop a bad side effect from the new drug that you otherwise would not have developed, and that's always there. There are so many unknowns with clinical trials. That's why it's a trial and not an approved treatment. That's always there. But when you face an aggressive disease that has a good chance of causing harm, I think we look for all the possibilities and all options to control that in the best possible way. For example, I met a patient once during my residency who was on a clinical trial 25 years ago, and that medication was like a breakthrough medication at the time that would not have been available to her if she didn't participate in the trial, and she would not have been alive today. So there are good things mostly, but you could also be one of those rare patients who develop a side effect. But these side effects are usually well studied in the phase 1 and phase 2 portions. So in phase 3, we kind of have a good idea of what could happen.
Right.
So the trial will also specify what are the things that we should be looking for. And there is extensive review and documentation of these things. There's monthly reviews from the central organization also. So it's really very well controlled.
And really detailed.
Yes, yes.
That's awesome.
Our clinical research nurse coordinator who works with us is actually employed by UNC, but on site at Nash. So that's a really nice connection for us to have, is that we easily participate in the trials that they have. Our physicians can engage and help. She can help research some of those.
And so if they are getting treatment at Lineberger in Chapel Hill, but they live in Rocky Mount, would they, and they were eligible for a study, would they suggest possibly, or?
Not in those instances, because the trials have, as I said, specific protocols. So if they get enrolled in a Lineberger trial, for example, there's a very good chance that it has to be administered there.
Okay.
But we do have independent trials of us in partnership with other national organizations where those you could get enrolled. Sometimes we have similar trials that you could benefit from, and patients could get a similar drug here, enrolling on a similar trial than traveling. So it's a case-to-case basis depending upon what the disease is
Sure.
and what the cancer is.
Okay, it's always good to know. So, if, you know, the treatment, you're in this trial and you can't tolerate that drug, you know, the trial drug, so then you just bow out and they continue with the standard of care. So there's no loss of anything, really.
No, the trial would specify what we call as toxicity assessment. So there are clearly given grades of measuring any side effect, be it a minor itching or a little bit of a headache or nausea, or just you just don't feel good. There are grades for everything, and we monitor that, and I do evaluate that and document that. The clinical trial nurse also monitors that. So it's going to be intense scrutiny than normally what you would receive. That's another benefit of a clinical trial.
Yeah.
You're going to have a more focused and detailed visit than otherwise you would
Sure,
have.
sure.
Once we identify that something is not right and there's a side effect, so again, there's specified protocols based on the severity of side effect. Either we dose reduce, hold the drug, or if the side effect is serious enough, then you come off of the trial.
Yeah.
And the trial central agency is notified, and there's a follow-up after that to make sure that that patient gets back to normal. And the patient will be followed despite the fact that they're not getting the drug anymore. That's also usually pre-specified, usually for a couple of years at least.
Sounds like you have a good safety net,
Oh,
so nobody
absolutely.
falls through the
Absolutely.
cracks. 'Cause-
Absolutely.
Something patients have often asked about is the financial implications for a
Yes.
trial. So certainly, cancer treatment is not cheap, and we have a financial counselor within the cancer center that helps patients on a routine basis. But the other advantage of a trial is typically anything that the trial, like the CT scans or the biopsy or the medication, is typically covered at no cost to the patient by the organization that's sponsoring the trial.
Wow, that's
So,
great. So, again,
So they get this
there's no
intense
loss for the
scrutiny. Right,
patient.
right.
You know, that's awesome. Because just a CAT scan, I'm sure, is thousands of dollars. I mean, I don't know, but I'm sure they're expensive. Everything's expensive. So, do any of the patients ever get compensated? I mean, you're compensated by getting the medicine and getting the imaging and stuff, but is there a cash cash payment as well? Is that something that happens?
Usually not in
Okay.
these trials, because then it complicates of whether are you trying to influence the decision
Right,
of a
yeah,
patient, is
yeah,
it coercion?
yeah.
So generally these trials are, the benefits of them is really the potential to have a drug that's not yet approved that you could immensely benefit from. Some patients don't have the 2 years or 5 years until this drug is actually out. And the way we've selected these studies also is looking at the disease, how aggressive it is, what's the standard of care available, is it great? If it's not great, then focus on those areas and bring these novel treatments.
Right.
I really think it's such a good thing to have these novel drugs available to some of the patients in a community like Rocky Mount.
Yeah. I
And
think-
some patients really are able to connect that the only way I'm getting the standard medication I'm getting today is because someone was on a trial before
Correct.
me
That's
years
right.
and years before.
Correct.
Because that's the only way the oncologists
They're
are
really
able
heroes, aren't they?
to, yeah,
They
to
are,
keep
they are.
moving it forward.
They're
And the fact
contributing
that there is so much data.
Yeah, they're
Yeah.
contributing so much to the body of evidence, and it's a collective knowledge that the human community has, and that came through hundreds of thousands of people who voluntarily participated in this trial.
Right. I think that's awesome. So how many trials do you have going over there now?
So right now, in terms of treatment trials, we have opened 3 in the breast cancer space. There's 1 in the colon cancer, and we do have 2 registrational or observational studies. we have another interesting trial. It's not a treatment trial, but again, it's going to contribute so much to the knowledge that we're going to gain from that. It looks at people developing neuropathy, which is tingling or numbness or pain and permanent loss of sensation in your fingers or feet from cancer treatments. And there's a particular drug called paclitaxel that is very well known to cause it, but it's a very good drug for breast cancer. It's a very good drug for lung cancer. So we are partnering how the drug affects the nerves and how this neuropathy happens, and patients get evaluated by us. The clinical trial nurse also does tuning fork testing to see how the nerves are functioning and how it's getting affected. That's, for example, is a very good trial, which is not a treatment trial, so it doesn't carry any of the side effect risks, but you're contributing so much to the knowledge that could be gained from that.
Yes, because that is a side effect. That
That's going to be life-changing for some people. It's kind of you cure them, but they're left with this unpleasant side effect. So knowing how that happens and understanding that better so that you can prevent that is going to be make a big difference in many people's lives.
It's just amazing, isn't it? How well, and we live in a crazy, chaotic world, but there's still a lot of good people that are going through and doing things like this, and you are doing it, and I think it's just wonderful. So do you have any patients that, and I'm sure I know the answer to this, that said, I shouldn't have done that, it was the worst thing I ever did? I bet not.
Usually not. People are usually motivated, they inspire us, patients do inspire us, and they find the courage and strength, and usually they are motivated enough to go through this. They generally take everything in a good, positive way. That's one thing that's very striking about cancer patients. You would think that it's a devastating thing, but somehow their faith or their family, they get the courage and the positive spirit to do these things.
That's just awesome.
Most of them do have a community of people that support them, because there are so many appointments that they have to come back and forth for. Whether it's in Rocky Mount or they have to drive somewhere, there's still a lot of appointments. So it really does take a team of people to support a patient while they're under treatment.
And I remember a show I had here that they had several volunteers. I don't know, was at the cancer center, but and that's awesome too, because those people, they just love those patients. And I can't remember the gentleman's name, but he was just
Mike Bowden.
Mike.
Everybody knows Mike.
He is such an inspiration. I really, every day when I see him, I used to tell myself, look at him, at his age, trying to help people, and he's on his toes all the time, and giving patients blankets, water bottles, helping the nurses. He's such a wonderful human being.
And there were several ladies too, and I just thought it was awesome that there's a great, this is a little off subject, but there is a great volunteer system over at NASH.
Yes.
Absolutely.
And
And we're just starting to be able to bring that back
Yes.
just in the last couple of weeks, which is really nice. Not that we have it all back, but pre-COVID we had pet therapy and music therapy and art therapy, and of course, like Mr. Mike was what we call a lay navigator. So those volunteers went through training at UNC on how to truly support patients who are receiving active treatment.
Because everybody loves a dog.
Right.
Most everybody anyway. Some people don't. All right, we're done with, it's time for our next break. And so we are going to come back in just a few minutes with more Dr. J and Sterling, and we will finish up talking about the Cancer Center over at NASH. We can never finish totally because there's always something going on, but we'll try to get the rest of it in the next few minutes. So don't go away, we'll be right back.
At Down East Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Down East Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Down East Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
I came to the emergency room because I was having what seemed to be an episode of AFib. I was very, very scared and wasn't sure exactly what was going on. They told me that they were going to do a catheterization. I was just totally blown away. The kindness, the compassion, the nurses. I was treated better than I've ever been treated in my life. I was just so excited that I could do it here at home at Nash UNC.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
Hi, I'm Richard Goss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, hello, we're back. Welcome to Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center. And today we are with Sterling Grimes and Dr. Jay Manicum, who work over at the Cancer Center at Nash, UNC Nash Healthcare. And so we've been talking about clinical trials, and a question that came up during the break was, how many, we live in a rural area. You know, we got a big hospital, but we got a rural area. Is that pretty common for rural areas, especially when we are wedged between Greenville, Raleigh, Chapel Hill, and Durham? There's so many tertiary care places. Is it normal for a small hospital like this to have these clinical trials, or is that?
It's not common, but it's not rare either. It depends on the motivation of the physicians there. More importantly, motivation of the hospital leadership, how much they want to invest in, partner with large institution on this, and how much of a vision they have for the future. And we've got a great leadership at NASH, the CEO and the administrative team. They've been very supportive of us doing these things, because a lot of times a clinical trial consumes more time. You could see 3 patients in that time and generate more revenue, but things like this consume more time, they consume more resources. For example, the Nash Hospital and UNC has given us a dedicated clinical trial research nurse who's paid full-time to do this, and that's really a great support that we receive. UNC has been a wonderful partner in that. Their institutional review board reviews our clinical trial protocols, so everything is approved through UNC Chapel Hill. They've been very helpful to build the treatment plans for this clinical trials. Now we have virtual meetings on those, and it's really a very wonderful service that the hospital has invested in. This is really a great vision that they have for the future, because this is where the future lies, and I think that's why we do these things here, and we are expanding these services.
I think that's awesome. And Nash has always been, even when they were just a little teeny hospital when I worked there, they've always been community minded. It's always been, we are here for the community, we want to make things better for you. And this is certainly a good showing of how they still feel that way, and we're still getting all that benefit. It's just great.
The partnership with UNC certainly helps
Oh,
bring
yes.
expertise
Oh,
to
yes.
our community.
That's right.
Right.
So,
Right. We've got the wish,
That's
but,
right,
but
that's right.
you've got to have a little bit more than that. You got, and so they could provide the extra. So that's great. So what are your? We were talking about a cancer conference, and I said I don't know what a cancer conference is. So what is a cancer conference?
So the Cancer Conference, or Tumor Board, is a forum where all the specialists or the experts in respective fields sit together and discuss complex cases. We meet every Friday, 7 o'clock in the morning. We've got a dedicated radiologist to review the images. We got a dedicated pathologist to review the slides. We actually do that in real time. The pathologist, brings, either the microscope or takes pictures of the slides. And there's surgeons in the room. There's urologist, our team of medical oncologists, and Dr. Giacomo, she's a radiation oncologist. You got the genetics folks call in from UNC. We got the research nurse calling in. So what typically happens, for example, is, I see a new patient this week, and the case is challenging and complex, and there are more questions that are unanswered yet. So I ask our the cancer conference coordinator to add the patient to that cancer conference. So we meet the next Friday and review the case. We go from the very beginning, patient presented with this and this, and we have this situation. And I ask the questions that I want answered. I ask the pathologist, can we double check on the pathology? Can we add these studies? And he reviews and he provides his expert inputs. The radiologist pulls up the scans and he double checks on things. And when we ask, can we pay attention to the liver area? There's something mentioned, but it's not very clear in the wording. And then they review it. Sometimes things do change based on these reviews. And then we do ask the surgeons, what do you think? So everybody is on the table and making the best treatment plan for that patient. We have a dedicated thoracic conference that meets on Wednesday, every other Wednesday in the afternoon, and we partner with thoracic surgeons from Rex Hospital in Raleigh. So they sign in and they call in over the phone, and again we do the same things. And it's very important when you have a complex disease like cancer, so that all the teams are all on the same page and then come up with the best plan for the patient.
Okay, so anybody that's on that team can bring a patient if
Correct. If they think that additional input or review is needed.
Do you need to get permission from the patient, or it's all?
It's
there's
all
no names or anything. It's just the.
But generally, we don't say the name. But if you do see it on, everybody is part of the healthcare team. It's not open to public. It's all the treating doctors or the treating team of that hospital who provides inputs. So
Okay.
we don't discuss the personal specifics of the patient, but we do discuss their disease specifics and come up
Sure,
with the best treatment
sure.
plan.
Do you get breakfast? Just kidding. They
do.
used to get breakfast.
So we do. That's
When it was the
another,
tumor board.
a service that the hospital, offers, and we do, yes.
Yeah, well, they have a great cafeteria.
Yeah, it's a
over
great
there.
gesture, yeah.
Yep, that's
The
nice.
thoracic conference is really nice though, because obviously lung cancer is our second most diagnosed cancer, as we talked about earlier. But we don't have a thoracic surgeon, which is a surgeon that does surgery typically on the lungs here, because they are so specialized. Rex Healthcare only has 2 in Raleigh.
Okay.
So that's why we're able to do a virtual conference, and but they're a part of that team that reviews those images to make
Yeah.
recommendations to our local team for patients.
Why is it that there's so few thoracic surgeons?
It's a highly specialized field, and it's a complex field too. You're operating close to many large and important blood vessels, and so you need to have a team that's trained, not just the surgeon, the operative staff and all this. And the volume, a general surgeon probably does hundreds of hernia surgeries or gallbladder removals, but lung surgeries are not that high in number. So as the numbers decrease and the complexity increases, you have the service only in tertiary. But the good news is our hospital has been working on that front and trying to explore possibilities of having a thoracic surgeon at Nash. So that's also in works.
Wow. So I see John Jones, and I send him in. He's a 40-year pack smoker, and I send him to Nash for a low-dose CT to look for cancer. And lo and behold, he's got it. Where does he go from there? What happens then? Will you send me a note, and I will refer you back? I will refer him back to you, or you pick him up and say, okay, Linda, I'm going to take care of him now. How does that work?
We do both, but
Yeah.
I'll let Sterling explain the
Yeah,
process
probably
of how it
depends
plays.
on what is found.
Okay.
Can I just back up 1 second? So
Sure.
mammograms, patients can refer themselves for a mammogram. But as you just said, you have to refer a patient for a low-dose CT screening. So that patient already has a primary care physician involved in their care, which is great as it relates to this. Because sometimes breast patients do not, is why I want to point that out.
Yes, I know. I have to write those orders.
Yeah,
for those.
sometimes they don't.
I'm the ambassador or whatever they call me. I don't know what it is. But anyway.
But a low-dose CT patient does. So depending on what the radiologist, that's who's looking at the study, what the radiologist identifies, comes back to the referring physician to give them guidance on what should happen next. Meaning a low-dose screening is the same thing as a screening mammogram, kind of, and meaning we're going to need some more images
Okay.
if we really think something's up. And so then, and they would recommend what kind of additional images, or we want to present this gentleman or lady at thoracic conference to get Rex's perspective, the thoracic surgeon, on what is probably the best thing to do next for the patient. Does that make sense?
Yeah, it makes a lot of sense.
It's just a very specialized area, and so there are a couple of different options, but it's great that there's a primary care doctor already involved in that patient from the beginning.
Well, yeah, I do.
But generally, the primary care doctor acts the doctor for the patient, because a lot of times you see something on the CT scan that doesn't necessarily mean that you got cancer. Patients get concerned.
Right.
That's the reason we don't get involved immediately. Generally, the primary care doctor gets notified, and we provide inputs, whether that needs to be biopsied or should the patient be referred to a thoracic surgeon, and then that happens, and once we have tissue that shows under the microscope that it is cancer, that's when you actually have to believe that it is cancer. Until then, fingers crossed, lots of anxiety, but the best thing is to stay calm and know what it is.
Yeah.
It could be just an inflammation. It could be an old pneumonia and a scar from that. But if you are a smoker and if you have multiple years of smoking and this low-dose CT scan shows something, I think the important thing is to follow up and follow the recommendations of further testing or a biopsy to know what it is.
Yeah, I'm glad to have that. That's it's a boon for me as far as being a provider, because of course I want the best for my patients, And I think it's great.
It is similar to a mammogram for the radiologist in that they want a baseline. So they want the patient to have a low-dose screening so that if they come back, they can compare it, which is all about what mammograms are looking at. They compare multiple years for a screening mammogram.
I think, if I remember correctly, anybody 65 and above can get it, even if they're not smokers, just because of their age. Is that right? Do you know?
For low-dose CT screen, it's usually for smokers with a certain amount of packing. Smoking history and the age.
There is some parameters if you've lived there. It's a little more complicated though. If you've lived in a household for a certain number of years with someone, I'm sorry I don't have it with me. There's quite a bit of information on our website about the.
Well, apparently I need to study that, don't I?
And there has been a recent update on that too. Generally, the previous one was if you're 55 years or above and you've had smoked for a pack a day at least for 30 years, and then you automatically qualify. And there's been an update on that in further relaxing the criteria because it seems to help people more than they originally thought. So, but if you had quit smoking and it's been 15 years, that's the time that it takes for all the bad effects to go. Then you kind of start to fall back towards a non-smoking population.
Oh, it takes 15 years?
Almost 15 years.
I knew that it could be, I don't know if reversed is the right word, but it could be backed up some, but I didn't know how long it took.
It takes, but there can be residual effects. These are general guidelines that apply for the entire country. You may be different as a person, so it's always worth checking with your doctor and having a conversation about the risks and benefits of it. Now, generally, in 80-year-old women, a mammogram is not recommended technically, but we have a lot of good 80-year-olds. They're going to live another 15 years. So we do find early-stage breast cancer. So just because a guideline is a guideline, that doesn't always apply to that particular patient. You have to take it, on an individual case-to-case basis also.
Yes. My daughter has a neighbor who is 99. She'll be 100 in December. She fell and broke her hip, went to NASH, got her hip replaced, went over to BTAR, and had her therapy, and she's back home in 2 weeks.
Wow.
She is
She's taking good care of herself.
Yes,
then.
ma'am. She's an ex-nurse at NASH too, so see, us nurses, we rock. All right, well, thank you. Is there one thing that you would like to highlight? We've got 1 minute left, so anything you want to tell our viewers, do this, don't do that. We don't want to see you, but if we do, I don't know. Sterling, you got something? Dr. Manican, you got something?
I think if you're a woman of at least 40 years of age, yearly mammogram once a year, that's what the Oncology Societies recommend. That's very important. If you're somebody who are smoking, the first thing is obviously to try to quit smoking, but in the interim also try talking to your primary care doctor about whether you should be getting an annual low-dose CT lung cancer screening. And if you're a man, you can talk to your primary care doctor about the risks and benefits of doing routine PSA screening, which is the test for prostate cancer. And I do want to thank you for listening to this, and we do want to say that we got a great cancer center, and we are working every day to improve that, and we have a good option of treatments and clinical trials available.
That's awesome. Sterling, you got anything you want to add?
I'll just piggyback on what he said. Anything that is called earlier is certainly easier for them to take care of and manage. So the more a patient can be in touch with their primary care physician and do screenings, just generally taking good care of themselves, will manage much better. And I hope we do not have to see anybody, but if we do, I really believe wholeheartedly in our team of physicians and clinicians, and I know that they'll
be well taken care of, as well here as anywhere else. So that's awesome. All right, well, thanks so much for watching. Thank you so much for coming, Sterling and Dr. Manican. And we will see you next week with more of Here's to Your Good Health. Good night.
Good night.
Good night.